Educational content by Dr. Mohammed Inyagi Mohammed. In this explainer, we're going to do a focused review of chronic kidney disease, specifically looking at its staging and classification. This is, of course, a core competency for clinical practice and a really high-yield topic for specialty exams. So we'll break this down into 4 key areas. First, a quick look at CKD etiology. Then we'll get into the principles of estimating the glomerular filtration rate. After that, we'll cover some critical caveats in eGFR interpretation. And finally, we'll put it all together with the definitive framework for staging CKD. Okay, let's start with etiology. Understanding the common underlying causes is really the first step in both identifying and managing chronic kidney disease. This slide really summarizes the main culprits. Now, diabetic nephropathy and hypertension, they're the big ones by far, accounting for the vast majority of cases you're going to see in primary care. But we also have to consider inflammatory conditions like chronic glomerulonephritis, infectious causes like chronic pyelonephritis, and of course that key inherited condition, adult polycystic kidney disease, which should always be on your differential. Right, so when it comes to assessing kidney function, we really have to move beyond looking at serum creatinine alone. While it was used for a long time, it just gives an incomplete picture. The standard of care now is the estimated glomerular filtration rate, or eGFR, because it's a much more clinically useful assessment. And that brings us to a fundamental question, one that's important both clinically and for your exams. Why is serum creatinine on its own just not good enough to measure renal function? Well, the answer really has to do with the variability in our patients. And here's the answer. It's all about physiopathology. You see, serum creatinine is just a breakdown product of creatine phosphate, which is an energy store found in skeletal muscle. So it follows that a patient's total muscle mass is a huge determinant of their baseline serum creatinine level. And that's what makes an isolated creatinine level a pretty poor marker of kidney function when you're comparing different people. So to get around this variability, we use the estimated GFR. Now, this is a calculation. It's not a direct measurement, but it gives us a much more accurate index of renal function. Historically, the MDRD equation has been used everywhere. It's worth noting, though, that most current guidelines actually recommend the CKD EQI equation now because it offers better accuracy, especially at GFR values over 60. So these equations, MDRD, CKD EPI, they incorporate a few key variables to adjust that raw serum creatinine. They factor in age, which makes sense because GFR naturally declines as we get older, and gender, which acts as a rough proxy for differences in average muscle mass. Now, historically, ethnicity was also included, but this has become a major point of clinical debate, and a lot of institutions are now removing that race-based coefficient from the calculation. This is due to real concerns about its validity and the potential for it to actually worsen health disparities. But here's the thing, and it's so important to remember this. The eGFR is an estimation. It's not a direct measurement, and that means it's subject to inaccuracies in certain clinical scenarios. Understanding these caveats is absolutely essential for interpreting the result correctly, and it's a favorite area to test on board exams. This slide highlights 3 critical scenarios. First, pregnancy. Pregnancy actually induces physiological hyperfiltration, which can make the eGFR look artificially high and potentially masks some underlying kidney dysfunction. Second, extremes of muscle mass. Think about patients with amputations or severe sarcopenia, or on the other hand, bodybuilders. These situations just violate the assumptions about muscle mass that are built into the formula. And finally, something as simple as eating cooked red meat can transiently bump up serum creatinine, giving you a falsely low eGFR. This slide gives a really powerful clinical illustration. Take a patient with an amputation. They have significantly less muscle mass, leading to a low serum creatinine and a potentially falsely reassuring high eGFR. On the flip side, a bodybuilder's high muscle mass will produce a higher baseline creatinine, which might result in a falsely low eGFR, possibly triggering an unnecessary nephrology referral. It just underscores a crucial principle. Clinical context is everything when you interpret an eGFR. Okay, so that brings us to the classification of CKD. Once we have a reliable eGFR, we can then stage the disease using established international guidelines. And this staging framework is fundamental for management, for prognosis, and for communicating with other clinicians. All right, this table lays out the KDIGO staging of chronic kidney disease. Stage 1 is a GFR of 90 or more, but, and this is key, with other markers of kidney damage present. Stage 2 is a mild GFR reduction between 60 and 89, which also requires that other evidence of kidney damage. Stage 3 is where we diagnose CKD most often. It's a moderate GFR reduction, and it's subdivided into Stage 3A, a GFR of 45 to 59, and Stage 3B, a GFR of 30 to 44, a distinction that has prognostic value. Stage 4 indicates a severe reduction from 15 to 29, and at this point, you really need to be planning for renal replacement therapy. And finally, Stage 5, a GFR below 15, is established kidney failure or end-stage renal disease. Now, this quote on the screen is absolutely critical, especially when you're thinking about stages 1 and 2. An eGFR of, say, 75 milliliters per minute does not automatically mean a patient has stage 2 CKD. There must be some other objective evidence of kidney damage. Without that evidence, a mildly reduced GFR, especially in an older patient, might just be a normal physiological change. Making that distinction is vital to avoid overdiagnosing and labeling patients unnecessarily. So what do we mean by other evidence of kidney damage? Well, in clinical practice, the most significant and common marker is persistent proteinuria, specifically albuminuria. We usually measure this as the albumin to creatinine ratio, or ACR. Other markers could be things like hematuria that's glomerular in origin, or even structural abnormalities you might see on renal imaging. The bottom line is, if a patient's UNEs are normal and there's no proteinuria or other signs of damage, you cannot make a diagnosis of stage 1 or 2 CKD based on the GFR alone. So let's end with a clinical scenario to bring this all together. A patient's eGFR is consistently 80 milliliters per minute. Do they have chronic kidney disease? Well, the answer, based on everything we've just discussed, is it depends. We simply can't make the diagnosis without more information. We absolutely have to assess for that evidence of kidney damage, with the most important one being the presence of albuminuria.